Thank you, Lauren, for that wonderful introduction. And hello, everyone. Thank you so much for joining this webinar. I am extremely excited to have the opportunity to talk to you all and give you a look into what individualized anesthesia looks like for your pet. I'll first briefly introduce you to our amazing team here at the University of Minnesota, as well as give you a look into some of the services we provide. Then we will spend most of our time going over the anesthetic process from workup through recovery, and hopefully leave some time for questions and discussions at the end of the talk. Currently, we are the only veterinary hospital in Minnesota with a team of board-certified anesthesiologists and anesthesia technicians to provide anesthesia as a specialty and as a full-time service. In addition to our 5 anesthesiologists, we have 4 anesthesia residents, and these are DVMs who have completed veterinary school as well as a year-long rotating internship and are working towards becoming a boarded anesthesiologist. We also have 12 certified veterinary technicians, 4 of whom have undergone additional specializations specifically for anesthesia. Additionally, we have a variety of other professionals on our service at any time, including those who are learning anesthesia through us, and these include a rotating DVM intern, DVM students, and we even started a program where we exchange residents for a week with a human medical school, so we have a human anesthesia resident rotating through with us as well. So what services do we provide as anesthesia specialists? We provide anesthesia for all species, including cats and dogs, horses, pigs, and many more. We also provide services of anesthesia for all the services in the hospital. So when your pet presents to the university for a procedure requiring anesthesia, we will be the ones to work with your pet. We also provide consulting services for anesthesia and pain medicine to the services within our hospital, as well as veterinary clinics throughout Minnesota and throughout the Midwest. Our mission is not only to provide clinical anesthesia, but also to teach the next generation of veterinarians and specialists, as well as to conduct research to generate new knowledge with the highest degree of ethical standards to improve the world of veterinary anesthesia and pain medicine. And I'm very proud to say that our faculty, residents, and technicians have won awards for their teaching as well as their research. To see what current clinical research studies are being done, you can Google College of Veterinary Medicine clinical research for the University of Minnesota, and a link will pop up and bring you to all of our open clinical trials. Now that you know who we are, let's get into why we are here tonight. And to do so, we first need to discuss what balanced anesthesia is and why it's important. Balanced or multimodal anesthesia is the use of several classes of drugs with varying mechanisms of action used together to improve anesthesia and pain control so as to decrease the over-reliance on one single drug and to reduce side effects associated with each class of drugs used. To place our patients in a state of general anesthesia, we need to achieve unconsciousness, muscle relaxation, as well as pain management. And we do this all while maintaining homeostasis, which is the body's natural way of maintaining its normal, healthy physiologic mechanisms. Because as I'm sure many of you know, anesthesia inherently messes with the body's natural maintenance mechanisms. Examples of balanced anesthetic protocols include the use of muscle relaxants and opioids, inhalant anesthesia, local block techniques, NSAIDs, as well as non-drug techniques such as icing a knee after a TPLO surgery. Not only do we maintain homeostasis through careful drug selection, we also do this through monitoring of all the body systems. We do this through hands-on monitoring of the patient, as well as with specific equipment. A lot of the equipment we use in veterinary medicine was actually designed for humans, so we have to be thoughtful in what we use and who we use it for. For example, in our very, very small patients, sometimes we need to use a different piece of equipment for monitoring of vitals such as blood pressure. Monitoring vitals, such as blood pressure, is really important because we want to maintain optimal organ perfusion and also function. We also have the capability in more complex or sick patients to place an arterial line for direct blood pressure monitoring. This is where a catheter is placed directly into an artery and we can get beat by beat readings of their blood pressure. Though arterial lines are the gold standard for accuracy in blood pressure monitoring, they're not without potential complications. So careful placement and maintenance of this is extremely important if we're going to use this in our patients. One of the other services I think I should take a few minutes to discuss with you all is our ability to perform precise local blocks for our patients. And instead of just doing these blocks blind, we are specially trained and able to use equipment to more accurately and effectively perform these blocks to achieve better outcomes for our patients. And that includes ultrasound guidance and nerve stimulation. And in order to discuss local blocks, we should first briefly cover the pain pathway. So let's say our friend here steps on a tack. Nociception, which is the body's ability to process that painful stimulus, will start to occur. First, transduction happens where the receptors or the nociceptors at the ends of nerves are activated. This then transmits a signal along the nerves up to the spinal cord. Here, some regulation might happen, but the messages are then sent to the higher centers in the brain where perception occurs. But it's important to know that perception of pain only occurs in the conscious or the awake state. When our patients are anesthetized, they're not conscious, and therefore perception of pain does not occur. However, nociception still occurs, and there are very negative consequences from the body's natural responses to nociception, such as stress hormone release, which then affects many body systems negatively. Additionally, it's important to remember that perception of pain will then occur once the patient is awake and has regained consciousness. That is why it's extremely important for us to provide balanced anesthesia and pain management to all of our patients. To do this, there are drugs and techniques that work at one or more steps in the pain pathway, for example. Those drugs include opioids, NSAIDs, and local anesthetics. So what are local regional blocks? Well, this is a technique that places the drug around or by particular nerves. Examples include, but are not limited to, epidurals, where the drug is placed in a space around the spinal cord to desensitize entire areas of the body, such as shown in this picture. These blocks are based on volume and where the volume spreads in that epidural space. Or we could do extremity blocks, which can target a specific limb, for example. Or we could do trunk blocks, which target structures such as the abdominal wall or areas of the chest wall. Common drugs for these blocks include sodium channel blockers, such as bupivacaine or lidocaine. So how do these techniques actually work, though? Well, when a drug like bupivacaine is placed by a nerve, it actually enters the nerve and blocks specific ion channels called sodium channels. And it prevents the transmission of the pain signal altogether from traveling up the nerve and allowing perception or even nociception to continue for perception to occur. There are many benefits to performing blocks, including being part of a balanced multimodal approach. This minimizes opioid use, decreases the amount of anesthetic and other drugs required, and it limits the side effects of these other drugs. It also mitigates the stress response to surgery, and there's actually a potential for rapid recovery. This is the only method that stops pain before it occurs. However, it is important to know that they're not without potential complications, and trained professionals should be performing these blocks. We're also very excited to announce that we are beginning to offer acupuncture to our clients at the University of Minnesota to bring our stance on the multimodal approach full circle. We currently have 2 of our anesthesiologists certified in acupuncture, which is Dr. Caitlin Tierney and Dr. Erin Hornicle, and soon to be 3, including myself, after I complete a program in August, as well as a few other clinicians here at the University of Minnesota. So in addition to providing your pet with the best anesthetic care possible, our goal is to get your pet back to normal as soon as possible after anesthesia. There's currently lots of discussion in human medicine about enhanced recovery after surgery, which is an evidence-based approach to surgical care aimed at minimizing the stress of surgery and supporting patients to recover quickly through maintenance of normal physiology. This approach begins even before admission for surgery and continues post-operatively, which is exactly what we aim to do here at the University of Minnesota. So with that, let's dig into what individualized anesthetic care looks like. At the University of Minnesota, we're very lucky to have experts in the field of anesthesia and the staff to support one-on-one patient care and monitoring in anesthesia. Though private practices do an outstanding job with the resources they have and can provide exceptional anesthetic care, a lot of the time anesthetic protocols and monitoring are performed very similar from patient to patient, and there can't be somebody dedicated to solely monitor anesthesia of that patient while somebody else performs, for example, a dental cleaning or a surgery. Each patient that comes to the University of Minnesota has their own protocol constructed specifically for them, from sometimes even before your pet even gets here and after recovery, with their own dedicated anesthetist. But why is this important for anesthesiologists and anesthetists? Why is it important for us to do this for our patients and to spend so much time? Well, unfortunately, as most of you may know, if you've ever been placed under anesthesia yourselves, there is an inherent risk of morbidity and mortality, so negative outcomes associated with anesthesia, even in healthy patients, though lower. This risk, however, goes up if patients are sick and have more comorbidities or other disease processes. So as you can see, the risk for anesthesia in healthy dogs is lower than if they were sick, and the same thing for cats. However, there's still an inherent overall risk when you combine all of those together. Another thing that we can point out here is that post-operatively is when a lot of the really negative consequences, including death, occurred. And we'll talk a little bit more about that later. So knowing this, it is very important for anesthesiologists and anesthetists to be able to expect certain complications and intervene if they occur before, during, or after anesthesia. So when teaching students, the way I explain this is that it's easiest to break down expected complications into 3 general groups. First are the expected anesthetic complications, which are closely related to the drugs we choose. For example, inhalants, the drug used that they breathe in to keep them under anesthesia, causes the vessels to dilate, which then can cause hypotension or low blood pressure. We must know this and be able to counteract this and fix this if this occurs and prevent this from even occurring. Next is procedural complications. For example, pain from an orthopedic procedure like a TPLO in a dog, for which we would provide things like a local block before the procedure were to even start, opioids, and icing after the procedure. Lastly are patient complications, which I will discuss in more detail on the next few slides. All of these groups are closely related, but to discuss and plan for these ahead of time means we are able to prevent or to more quickly act when they do occur. So what are some examples of expected patient complications? As anesthesiologists, we get many breed-specific questions, concerns, and requests, some of which hold scientifically backed proof and evidence, and others which do not. Some breed-specific concerns of note are those breeds that are predisposed to certain diseases, such as heart disease, for example. So let's take our Doberman Pinscher. They can be predisposed to a heart disease called dilated cardiomyopathy, or our Cavalier King Charles Spaniel, who's maybe predisposed to degenerative mitral valve disease. Not all dobies or cavies will get these diseases, but it does occur in much higher prevalence than other species. As anesthesia providers, it is important for us to know about these diseases because they are not all treated the same under anesthesia, especially if complications such as hypotension arise. Consider our cavie with degenerative mitral valve disease and a Maine Coon that has hypertrophic cardiomyopathy. The cavie's heart with mitral valve disease has a harder time pumping blood forward because of a leaky valve. And the Maine Coon has a problem with actually filling the heart with blood because it's pumping so much and so hard. Both cases are causing a decreased cardiac output or low blood amount leaving the heart and a low blood pressure. The cavie's problem might therefore require a higher heart rate to maintain blood pressure, but a higher heart rate in the Maine Coon could cause a more severe problem and more severe hypotension. Other breeds may be predisposed to endocrine diseases such as Addison's disease or Cushing's disease, which are essentially opposite problems of each other and require special considerations when they're being anesthetized. Or maybe there's a breed that's predisposed to a genetic mutation in the body's ability to handle certain drugs, such as MDR1. Here, we may choose to decrease a dose of the drug given or reverse drugs after a procedure to assist in recovery. Another thing to consider is just the conformation of our pet. For example, high muscle mass and low fat may just be inherently more sensitive to drugs, so like our sight hounds, and careful dosing might be necessary. Or even monitoring of blood electrolytes might be warranted because there are some case reports of potassium increasing under anesthesia in certain sight hounds. Another common conformation example is our brachycephalic breeds. Well, what is brachycephalic airway syndrome? This is a condition our short-nosed breed dogs like bulldogs, Frenchies, and Bostons have. Though cute, causes an increased risk for anesthesia compared to other dogs due to breathing difficulties that accompany this look. These breeds have smaller, weaker airways, including the nose, trachea, and have extra tissue in the airway that makes potential airway obstruction very, very likely. Therefore, a very carefully constructed plan and monitoring of these patients, both before and after anesthesia, is absolutely vital. If brachycephalic obstructive airway syndrome has been diagnosed in your pet, there are corrective procedures that can be done, which decreases their risk of anesthesia by up to 79%. What about other patient factors do we consider in anesthesia? What about other factors such as size? A very small patient may take more drugs on a milligram per kilogram or milligram per pound basis than our larger breeds. They also are very likely to get cold very, very quickly compared to our larger patients. So we have to be very aggressive with our heat support for these patients. Additionally, our very young patients need to have glucose monitored and have very different homeostatic mechanisms to maintain their blood pressure as compared to our adult patients. So choosing drugs in our very, very young patients that maintain a higher heart rate may be key in these cases. Though some say age isn't a disease, being older or geriatric does have considerations that we need to keep in mind for anesthesia, such as decreased drug requirements. In veterinary medicine, we actually define geriatric as an animal being 75% of their life expectancy. But what about other conditions throughout life? What if we have a pregnant patient, for example? We then have to not only consider mom, but also the unborn babies if they're requiring for anesthesia for an emergency or a C-section. There are many other disease processes that we need to keep in mind with very different management styles, from megaesophagus to intracranial disease, that require very careful protocol planning. But we do these all the time with great success and great outcomes. So with those examples of considerations under our belts, let's move on in the process. A dedicated anesthetist is put on every single case, every single patient that comes into the hospital for anesthesia. This anesthetist is one of our certified veterinary technicians, one of our DVM students, or one of our anesthesia residents. They will receive information about the patient and the procedure and will begin to work this case up by looking through the patient profile, either a day in advance or hours before the procedure. They go through the history of the patient, previous diagnostics that were performed, medications that the patient is on, including supplements. Sometimes on very complex cases, we huddle with all of the services involved. A physical examination is always done by the anesthetist as well as the receiving service. And then a plan is come up with and tailored to the individual patient and the procedure. After a protocol is chosen, the case is rounded on in detail with a supervising anesthesiologist for the case. This protocol is then checked and approved. I mentioned medication history in the previous slide. As the anesthesia team, it is very important for us to know what medications your pet is on, or we may even recommend medications to give to your pet prior to their visit. If your pet is very anxious or nervous at vet visits, there are medications your veterinarian can prescribe that make these visits more comfortable for them. Common examples being trazodone or gabapentin. This is not only decreasing the stress and anxiety to your pet, but also makes it safe for both the pet and the veterinary staff at the hospital. So it is very important that these medications are given prior if we think that it's necessary for your pet. Additionally, there are certain medications that we would like your pet to remain on. For example, particular heart medications such as pimobendan, as this is a common medication for heart diseases like degenerative mitral valve disease that we discussed earlier. This medication helps that heart pump that blood. Or if your pet has an endocrine disease such as Addison's disease, we will ask your pet to get an extra dose of that steroid that they're on leading up to in the day of anesthesia. Or diabetes, for example. Since we require fasting the day of the procedure, we will adjust your insulin protocol accordingly and monitor your pet's blood sugar before, during, and after anesthesia very carefully and closely. On the other hand, there are medications we may ask you to stop the night before or the day of anesthesia, such as ACE inhibitors like enalapril and angiotensin II receptor blockers like telmisartan. These drugs can interrupt the pathway where we treat hypotension under anesthesia. There are other medications that might need 5 to 7 days to clear the system, like clopidogrel, also known as Plavix, due to their mechanism of action on the platelets or the body's ability to clot or stop bleeding. This is why it is important to provide a complete list of any medications your pet is on, including supplements, as we also consider the potential for drug interactions. So it's time for your pet to have their procedure that requires anesthesia. A very common question that we get is, why do we ask for such an early drop-off time? The receiving service, as well as the anesthetist, will always do a physical exam the day of, making sure your pet has the green light for anesthesia. We will get a current weight the day of for very accurate drug calculations. This is especially important in our teeny tiny patients. Sometimes we also request additional diagnostics to be performed, including blood work or radiographs of the chest, or even an echocardiogram of the heart if your pet has a heart murmur. This early drop-off time allows us to coordinate these action items. Additionally, our anesthesia schedule is not made until the night before, and this early drop-off time allows us to change things if emergencies come in. So at this point, a protocol is set in place for your pet. And so please drop off your pet at the requested time. If that doesn't work for your schedule, there is even an option to drop off your pet the night before. Another common question that we get is, why should you do pre-anesthetic blood work for your pet? We have protocols pending the health status of your pet as to when these labs should be performed and what time window, meaning is a month ago okay, is 3 months ago okay, or do we require blood work the day of? And though, as you can see, the blood work doesn't necessarily change the outcome of what protocol we use, it has provided a new diagnosis for patients and has even made us postpone surgery or anesthesia to evaluate and treat the condition that wasn't previously known before. A common example of this being kidney disease. Another commonly asked question is, my pet has a heart murmur. Do I really need to get an echocardiogram before anesthesia? Well, unfortunately, the type or the severity of that heart murmur does not tell us what heart disease is present. And heart disease increases the risk of anesthesia and for morbidity and mortality. And protocols can be tailored more accurately, and complications can be treated differently depending on what heart disease is present. If anesthesia was an elective procedure, it may even be postponed so that treatment can occur to stabilize your pet prior to anesthesia with medications or even interventional treatment. So now that we have an approved plan in place and your pet is ready for anesthesia, we still have to get everything ready. And this involves a full equipment check and gathering the appropriate supplies. Once all of this is complete, we will then go get your pet and bring them to the anesthesia prep room, where they will be pre-medicated with their selected protocol. This will allow your pet to become sedate and allow for placement of an intravenous catheter and monitoring equipment, as well as to provide pre-oxygenation to your patient. For our brachycephalic breeds, we may even add a medication with the oxygen to help maintain their airway, which has been proven to help brachycephalic obstructive airway syndrome from occurring. And that's what you can see being done here in this picture. Once we've checked your pet's vitals, we will do a check-in with the anesthesian team, and then we will then move forward with induction, which requires additional drug administration to put your pet under general anesthesia. We will then intubate your pet by placing an endotracheal tube in their airway, which allows us to provide oxygen and the anesthetic gases that they will breathe that will keep them anesthetized for the procedure. Our job is to then maintain your pet in a balanced state of anesthesia and monitor, monitor, monitor. A lot of the things that we use to maintain anesthesia of your pet include a lot of the things that we talked about to maintain anesthesia in that triangle that I showed you very early on in this discussion. We can use inhalants. We can use constant rate infusions, which this is a very extreme example on this slide, but we can give drugs over a determined amount of time. We can do local blocks that we talked about in detail. We will provide antibiotics if indicated. We will give your patient fluids to maintain their normal hydration status. We will provide blood pressure support if needed. We will move around the hospital with your pet while they're anesthetized while doing all of these things. And we monitor, monitor, monitor. I don't expect you to see this teeny tiny sheet, but we write down vitals every 5 minutes, but we are constantly monitoring your pet under anesthesia. And we do many other things as well. Once the surgery or diagnostic procedure is complete, we will then wake up your pet. And this isn't as easy as said than done. This was part of the discussion with the anesthesiologist and the team in the beginning as to where and how this will happen. And some of you may already be aware, though, that induction, so the beginning, and recovery can be some of the times where major complications can arise. And that is why we still monitor your pet very, very closely during these times. Once your pet is able to maintain their airway, meaning that they have certain laryngeal reflexes present and they can swallow, for example, we will remove that endotracheal tube and still monitor and provide oxygen support via face mask until they are deemed able to be moved while they will finish their recovery process. During this time, We will continue to monitor vitals. We'll reassess your pet for any pain if they had surgery or any other painful procedure performed. We then transfer our non-critical cases to our post-anesthetic care unit, where a dedicated attendant will continue monitoring and providing for your pet the care that they need. For example, here is where we might use our game ready machine to apply cold compression therapy to patients who had orthopedic surgery. It has been proven, as we discussed, that up to 2 hours post anesthesia and surgery, that's when a majority of complications can arise, including resedation, as well as regurgitation and aspiration. Therefore, we continue to monitor your pet until they are deemed stable enough to return to patient wards. Our more critical patients, however, recover in our intensive care unit with our emergency and critical care team. Anytime a patient leaves our care, we round with whichever team will then be responsible for your pet's care and inform them of the procedure done, the drugs that were given, and any continued care necessary if needed. Care for your pet doesn't always end once they are deemed awake enough to go home. It is important to remember that just like us, your pets may be groggy for some time after recovery. They might be groggy for up to 24 to 48 hours. This is going to depend on a lot of factors, including what procedure was performed, what comorbidities or diseases does your patient have, how long was the anesthesia, and what drugs were used. Additionally, it is important to know that the age and the temperament, or how anxious the patient was prior to anesthesia. For example, we know in our elderly human patients that sometimes it can take days for them to come back to normal, to a normal mental state after an anesthetic procedure, even if relatively short. This can actually be very similar to our veterinary patients. We also have to keep in mind that we know in our human patients that inhalant anesthesia can cause GI upset and post-operative nausea and vomiting, which is the PONV you see there. This is something that we consider a lot in our veterinary patients. We translate a lot of human medicine into veterinary medicine, and a lot of care goes into what drugs that we use for your patients. So with that, I wanted to thank you for your attention. And I just wanted to end by saying that as an anesthesia service, we're always happy to talk with clients about their pets' anesthesia care and answer any questions that you might have. And I know we ended a little bit early, but I wanted to be able to answer any anesthesia related questions that any of you have tonight.
All right, thank you so much, Dr. Ienello, for that detailed presentation and walking through those different points with us. So we did have a handful of questions that came in before the talk, so we'll jump in and then we'll get to the ones that come in as well as we continue. So this came up a lot, and I know this is pretty common reason that people might have their pets be anesthetized. So what are the general risks for dogs and cats being anesthetized for dental work?
That is a really good question and a really common question. As we know, and as I'm sure everybody listening knows, that dental care or oral care for your pets is very important and has been proven to even extend their life expectancy when done properly. And so it is important to get your pets in for even routine dental cleanings. And though I know that's not possible for everybody, if you can, it's something to consider. As for anesthesia, as you saw on that slide that I have, even in healthy patients, there is an inherent risk of anesthesia. But when we're talking specifically about dental procedures, the biggest thing that we need to consider and think about is aspiration. So I showed you all a slide where there's an endotracheal tube that we place in the airway. That is to maintain them under anesthesia so they can breathe in the inhalant, and we can help them breathe that inhalant and that oxygen in. When we do that, we always have to check very carefully if it's a proper fit. And to do that, there's a little balloon on those tubes that we can very gently expand, and so there is a appropriate seal. sometimes when inflating that tube on any case, this isn't just dental cases, that tube can be inflated too much. It can cause damage to the trachea. Now you place that same tube in a patient that's getting a dental procedure where there's a lot of head movement around on the table. You can actually cause tracheal damage much more easily if you're not taking care of how the head is moving with that endotracheal tube in place. Some might ask, well, why do you have to place that endotracheal tube? Well, without it, maintaining anesthesia would be much more difficult. It would have to just be done through intravenous, but we need to protect that airway too. And so another complication is that they can aspirate some of the fluid when you're rinsing out the mouth. If that seal isn't appropriate, some of that water can get down past that tube into the airway and into the lungs and cause aspiration pneumonia. And so I would say for dental procedures, tracheal damage and tracheal tear, which can be pretty severe complications sometimes, is a risk, as well as aspiration pneumonia. Here we instill it in everybody who's anesthetizing any of our patients, and not just for dental procedures, to be very careful with head movement. And anytime we're going to be moving the pet, that we actually have to disconnect them from the anesthesia machine, which provides the inhalant and the oxygen, gently move them while holding the tube, and then reconnect them. And that's something I strongly encourage every practice to be doing.
Great. This came up too. I know you talked about different specific factors for pets coming into procedures. So does my pet being overweight contribute to any risks for being under anesthesia?
That is a really good question as well, and also a really common question. And though it's not necessarily a disease like heart disease or an endocrine disease like Addison's disease, being obese or being overweight is actually an increased risk for anesthesia. Not only has it been proven to decrease life expectancy and mobility problems for your pets, but when they're under anesthesia, that extra weight can actually hinder their normal respiration, which when we anesthetize them, breathing becomes a little bit more difficult naturally, and we have to support that. When they're obese, that's even more difficult for patients that are under anesthesia. That's a lot of extra weight that they have to breathe against. And so there is an increased risk. That includes for airway, and all sorts of things that we need under anesthesia. And so when we do have cases that are obese or patients that are obese, this is something that we talk about when rounding with the anesthetist, that we need to be careful and monitor their ventilation or their breathing while they're under anesthesia, and assist them and put them on a machine that will do the breathing for them if necessary.
Sure. So you talked about this a little, but we did get a lot of breed-specific questions. So can you talk about how anesthesia affects certain breeds like sighthounds, brachiocephalic dogs, or breeds that are sensitive to certain drugs like ACE, and maybe an extension to that of how people can kind of advocate and raise this in conversations with their veterinarian when they're considering procedures that would have anesthesia?
Yeah, of course. So like I briefly mentioned in one of my slides, the biggest breed-specific concerns that we have are the diseases that they might be predisposed to. Sometimes we get requests from certain breeders and cases, and though may have found their information somewhere where they thought was valid, asking for us to not give a specific drug, for example, like ketamine, or they have a sight hound or a boxer and they don't want to give acepromazine, for example. I would say that for us, we look at every patient as an individual, which is the point of this talk, and try to pick a protocol. And sometimes that might be one of the drugs where they didn't think that their pet could get. And so, for example, our sight hounds, we don't use this drug anymore, but a drug that a lot of people would say to stay away from was thiopental. This is an induction agent, so something like that we use propofol now, but works differently, and we use propofol now instead of thiopental. We also can't get thiopental in the United States anymore, but that did cause certain problems for our sight hounds. As I mentioned, they have a higher muscle content and lower fat content. And one of the things that our drugs do when we administer them in the body is they actually go into our tissues too. And so thiopental actually lingered for a very, very long time in our sighthounds, and recoveries were really rough. And that was actually different than some of our other breeds. Our brachycephalic dogs, that's something I talked in a little bit more detail, but our biggest worry for them is their airway. They have, even just being awake, have a really hard time breathing. You can see that with your pets in the summertime or when it gets humid, that they have a harder time getting around. And when we anesthetize these patients, that beginning, so after pre-medication and recovery, we are really, really worried about those patients obstructing their airway. And there actually have been anesthetic deaths in healthy patients being anesthetized, these brachycephalic breeds, because they obstructed their airway at induction and recovery, and maybe it was accidentally missed. So we take great care in the protocols that we choose and what we're doing in the beginning of the end. We're always making sure that, like I said, we have everything ready ahead of time. After we pre-med them, we keep a very close eye on them. Basically, they don't leave our site. We pre-oxygenate them very well. They have smaller airways, so we choose different size endotracheal tubes, smaller than what you think might be necessary. And then at recovery, we leave that tube in there, so that endotracheal tube in their airway for as long as they want. And sometimes we notice that they actually just like keeping it there because they can breathe really well. And then after we remove that tube, we have to keep a very close eye on them, that they don't resedate enough and that those airway muscles aren't relaxed enough where they might obstruct. Those cases, the ones where if your veterinarian does say, yes, you know, our Frenchie friend does have brachycephalic obstructive airway syndrome, they have a really long soft palate, they have really small, tiny little nares, they have other problems inside their mouth that can actually obstruct their airway. There are those procedures that I said, so there are actually surgical procedures that can be done to help your pet not be so prone to obstructing their airway. And this actually helps with anesthesia. And we're always happy when we see that those that were diagnosed with that had that procedure done. Though it doesn't completely eliminate the risk, it just helps a little bit more. The breeds that are specific to certain drugs is a little bit trickier of a topic. I would say, you know, there's some talk about UK boxers being really sensitive to acepromazine. I would say that clinically, I haven't seen that happen in any of our cases. And if it's a patient that we think that drug specifically will help them out for their procedure or just for anxiety, we don't completely turn our heads because not all of it is backed by evidence-based medicine. And we will carefully choose that drug dose. So meaning we might start with a much, much smaller dose than we would in other patients. And so it's just careful dose choosing and weighing your pros and cons for those cases.
Sure. This is a follow-up to something that you mentioned during the presentation. Could you address the use of reversal drugs?
Yeah, of course. So reversal drugs aren't always given to all of our patients. So for an example, a drug that we commonly use is opioids in our patients if they're going to be having a painful procedure. There is a reversal drug for that agent, for the opioids that we use. And say, for example, a patient is waking up and they seem very, very comfortable. We did a local block and it worked really well for their TPLO surgery, but they woke up poorly, meaning they're kind of thrashing, they're screaming, and we would say is a very poor recovery. But just like humans, our patients can have different reactions or they react differently to drugs. So for one person, that opioid might cause euphoria. They feel great. But then you give that same drug to somebody else and they just are they don't feel great. They're all over the place. They're kind of freaking out, right? And so that's the same thing for our veterinary patients. And so we can actually reverse that drug and take it away. And that will decrease those negative side effects that we see. Like I said, we don't always do it. We wouldn't take a drug away if it was doing something that we liked, and like, for example, they weren't having that bad reaction to that opioid and they needed it for pain control, we would keep it. But if we did have to take it away, there's always different opioid options. We have the luxury here that we have different opioids that we can choose from. And so just like I said, where one can work for one patient and not for the other, we can choose a different opioid for that one that it wasn't working for. The reversals are used, like I said, selectively if a patient is having a really long recovery, didn't have any complications, but they're just snoozing, and an owner needs to come pick it up and it's been 5 hours after anesthesia and everything's looking good. They're just super groggy. If we gave them a sedative, there are certain reversals that we can give for that. I will say it is not without any drug that we give isn't without potential complication. So giving these reversal agents, we don't just give them to everybody. We have to weigh the pros and cons, just like we do for every patient, because there can be some negative consequences of those reversal agents. And so if anybody has specific questions about any specific reversals, I'm happy to answer those. But I would say it's also important to know that not every drug has a reversal. For example, the inhalant that they breathe in, we can't just reverse that. It has to, basically the patient has to breathe it out. And the longer the patient is under anesthesia, the longer it's going to take them to breathe that inhalant out.
Interesting. Okay, here's another question that's more related to pain management. Do you have concerns about dogs taking carprofen for extended periods of time?
That's a really good question. And I would say that this is always going to be on a case-by-case basis, and always a discussion that you're going to have with your veterinarian who is managing pain, which I'm assuming that's most of the reason why our patients are going to be on an NSAID like carprofen, for example. And I would say with proper monitoring and proper dosing, I'm not concerned. I actually have my own dog who has some arthritis that's developing, and he does really well on a once daily dose of carprofen. And so long as we're monitoring, meaning like all of our drugs, there can be certain side effects. And so NSAIDs in particular, you're looking at liver or maybe even kidney values while you're giving this drug. And so long as everything's staying good and monitoring, and there's no GI side effects as well, I don't see any problem with extended use of NSAIDs. We want to always dose, though, to what works. So if you are starting at a certain dose and you're like, wow, this works great, I would see if maybe, you can maybe dose reduce and get to a point where it's just enough so it works, but it's not extra, because remember, all of our drugs have dose related effects. And so trying to find the right dose for your pet is what's going to be really important, as well as monitoring.
Yeah, I think there's, a lot of uncertainty sometimes with owners about whether or not there are conditions where you would advise not putting their dog or cat under anesthesia really at all. Is there anything that you can think of in that area?
I would say that we have anesthetized some very sick pets for very important reasons. And with any case, again, I've said this a lot, but we have to weigh our pros and our cons. What is the reason that they need to be anesthetized? Is this an elective procedure that isn't going to help with quality of life? And do they have some disease process that isn't being managed? I wouldn't say there's something where I would be like, nope, absolutely not anesthetizing that. We will help, any pet that comes through our door that needs it, and do the best job that we can. So I would say if they're being anesthetized for an elective procedure, so like a spay or a neuter or a dental that, they don't have a fractured tooth that's causing them very severe pain, can we get whatever disease process managed and under control prior to anesthesia? That is what is first and foremost the most important thing that we're going to recommend. I bring up heart disease a lot because we see a lot of patients with heart disease, and for example, like the mitral valve disease cases, it depends on which stage. I think Dr. Allison Masters had a talk about mitral valve disease and the different treatments that we can do. So if you haven't listened to that talk, that's a good one to listen to. But we do, if they need to be on medications like pemobendin, we would prefer that beforehand if possible. Can we manage a patient that it's an emergency? For example, say it is a foreign body that's obstructed, in the stomach, and it has to be removed surgically, or their stomach is twisted, GDV, for example, that needs an emergency surgery and anesthesia. We will still anesthetize them and do the best that we can, but to decrease the risk of anesthesia, it's always best to have these things treated and managed appropriately ahead of time. So when I'm asked that question, what won't you anesthetize? I don't have an answer for that, but I think it's important for you and your healthcare team to weigh those pros and cons.
Sure. Here's a question that came up about blocks. So are abdominal blocks being used commonly post-spay for adults?
Could you repeat that question? Was it
Sure.
abdominal blocks?
Yeah. Are they used commonly post-spay for adult patients?
That's a really good question. I would say here, we are trying to implement doing local blocks or those local anesthetic techniques that I spent a little bit of time to talk about on any case where appropriate. Because like I stressed in the beginning, that multimodal approach is very, very important. And so for us here, we do usually do it's basically a line block where we inject that local anesthetic on the line of the abdominal wall where the surgeon is going to be cutting to open the abdomen and to, perform that spay procedure. So we are putting local anesthetic there. So I would say here we're definitely trying to do that. And I would say all the cases that I round on, we do talk about doing a local block for those cases. I would think out in private practice, I'm lucky enough where the DVM students that we have coming through have all worked at or, shadowed or been to a lot of private practices in the area, and they do a lot of line blocks for their space as well.
Great. You talked a little bit about heart disease. So someone asked, what were the anesthesia precautions you mentioned for Maine Coon cats with cardiomyopathy?
That is a very good question. So the problem with hypertrophic cardiomyopathy, and remember, this isn't just for Maine Coon kitties, it can be for any of our patients, dogs or cats. It's a heart disease where basically the heart muscle gets really thick. And then so the heart muscle, which is a muscle, just pumps extra hard and extra fast and long. And so what I mentioned briefly was that the problem with those patients is basically trying to get blood into the heart so it can pump the blood out. And so that's a completely different problem than our mitral valve disease cases or dilated cardiomyopathy cases. And so anesthetic concerns for our HCM kitties is trying to actually maintain, we want a lower heart rate. So a lot of the times these cats will be on beta blockers, such as depending on the cardiologist or the veterinarian, something that ends in like a lol, like atenolol, to try to help decrease that heart rate. And so that's something that we try. What I would say, what risk is there or what factors do we think about? It's like I said, basically us just trying to maintain homeostasis. And when our HCM kitties are being anesthetized, we will pick most of the time drugs that will actually potentially help decrease the heart rate, as well as drugs that maybe the vessels that the heart is pumping into We try to maybe give them a little bit of a squeeze, meaning we constrict them a little bit and they're not more dilated. So instead of them being really wide open and the heart is able to slam the blood out really quick, we make the heart have a little bit of a smaller hole to pump into, so as to keep the heart a little bit more full. Remember I said it's the heart being full is the problem for these guys, is kind of the basic non-cardiologist. Remember, I'm an anesthesiologist, cardiologist way of explaining that heart disease. But again, like, just because that's generically what we say for HCM, maybe there's a cat out there under anesthesia that we're actually, oh, you know, we think that this kitty is subclinically dehydrated, meaning maybe it needs a little bit more fluids, and it's something that's not picked up necessarily on a physical exam. And so we want to give that cat fluids instead of, you know, worrying so much about the heart rate and things like that. And so when our cases are anesthetized, we're always looking at the whole picture, all of the vitals. There's not one thing, you know, I keep talking about heart rate for these cats or for HCM, but that's not the only piece of the picture. And so if you do have a cat with HCM, I would say if it's being managed on certain medications, you know, and being evaluated, that's the best thing that we can do, or you can do for your pet prior to anesthesia. And then having us know that, you know, what stage, how bad, how sick is the heart? You know, we like to know what an echocardiogram shows. We look at that, look at dimensions and changes, and we tailor the plans accordingly. So it's all patient dependent.
Okay. I think we have time for one more question. So how do you manage anesthesia for pets known to have adverse reactions to certain drugs or vaccines? That was something asked ahead of time.
That's also a very common question we get. And we also get a lot of patients referred to us from primary veterinarians because of, you know, an adverse drug reaction. And the first thing that I want to say is we would like to know, okay, what happened? What was the full story? Again, this is the history part that we want to know, because a lot of the times it is that, you know, a drug like dexmedetomidine, maybe some of the listeners are familiar with that drug. It's very commonly used in veterinary medicine and in human medicine, causes a low heart rate. And that's one of the side effects of the drug. We know that, we expect that, we know that's going to happen. And sometimes we have pets come to us where, you know, the adverse drug reaction was an extremely low heart rate after a high dose of dexmedetomidine. And so we look at that and we say, we wouldn't necessarily call that an adverse drug reaction, right? That is a normal side effect of the drug. It's not common that we actually see true adverse drug reactions. I say side effects, meaning, you know, that those are negative things, but all drugs that we give cause certain effects. And so we can just throw the side effects in there. So if this is an allergic reaction, that's something, you know, we will treat ahead of time with Benadryl, so diphenhydramine, maybe a steroid, and maybe avoid that drug. If it's a drug we have to use, maybe we do lower doses, maybe we monitor extra close, right? Because sometimes we don't have certain options. So I think it's important to know the mechanism of action of the drugs, what effects those drugs will have on our patients, and then manage those appropriately. So vaccines, that's something a little different. So what is in those vaccines? So that vehicle that vaccine is in is what's causing the adverse reaction. A lot of the vehicles that our drug is in, so basically the holder, the liquid, is made with something different. And so we don't see the same effects like you would with vaccines. And so that's my brief answer for that.